So it's a great pleasure to welcome you all for today's session, New Year Medical Oncology Treatment 2025. And to start the meeting, so I would like to invite for the first speaker, Dr. Abhishek Bansal, SSB Hospital, QRG Hospital, and ESI Hospital, Faridabad, and to give his talk about reimaging CNS mutation in EGFRM advanced lung cancer. And this session sponsored by AstraZeneca. So it's over to you, sir.
Yeah. Can you put on the slides? Hello.
Yes, sir.
Can you put on the slides or what? I, I should I share or what?
So if you require, so I will share, sir.
Okay.
So can I share from my side?
Yeah, yeah.
Sure.
So good evening, everyone. The topic of today for me is reimagining CNS mutations in EGFR mutated advanced lung cancers and how treatments compare. Next slide, please. The incidence of non-small cell lung cancer. This is all which we know. 85% is non-small cell, and 15% is small cell, out of which uh, EGFR is the most common, counting for 17% in the among all the mutations present in non-small cell lung cancer. And next slide, please. There is marked geographical variation in EGFR mutation prevalence ranging from 15% in Europe to 62% in Asia. So maximum incidence being in Asia. Next slide, please. So patients with lung cancer have the highest rates of identified brain mets, and such incidents are more pronounced in EGFR mutated lung cancer. At final follow-up, 44% of patients with EGFR mutated tumors had brain metastasis compared with 22% of patients with wild type EGFR. Leptomeningeal has poor prognosis when not treated, survival of 4 to 6 weeks only. Leptomeningeal metastasis may be more frequent in patients with EGFR mutated non-small cell lung cancer versus wild type EGFR mutation. Next slide, please. Approximately 10 to site of metastasis affects quality of life. Patients with a single brain mets experience the greatest decline in quality of life compared to the other site of metastasis. Next slide, please. Main metastasis in EGFR mutated advanced non-small cell lung cancer and TK. Next slide, please. The brain is a sensory site for invading metastatic tumor cells as it is protected by the blood-brain barrier. Up to 40% of patients with non-small cell lung cancer with EGFR mutations will develop brain metastasis. EGFR TKIs are also substrates for human blood-brain barrier reflex transporters to varying degrees, and this influences the distribution of compound in the brain at equilibrium. Hence, it is imperative that EGFR TKI must have good brain exposure if they are to achieve intracranial efficacy. Next slide, please. Next slide, please. Osimertinib penetration in the brain is much high as compared to the other drugs like gefitinib and afatinib, as done on the studies in the animals. Next slide, please. Next slide, please. And it causes tumor regression in EGFR mutated brain mets in mouse xenograft model. Next slide, please. Osimertinib was homogeneously distributed in all regions of the brain in healthy volunteers. Next slide, please. Osimertinib achieves brain exposure in patients with EGFR mutated advanced non-small cell lung cancer with brain metastasis. Next slide, please. Osimertinib binds irreversibly to clinically relevant mutant EGFR forms to selectively inhibit EGFR kinase activity, and it prolongs the PFS and OS related to first generation EGFR TKIs, and it has the high blood-brain barrier penetrance and brain exposure related to other EGFR TKIs, and it is active against CNS mets and it inhibits the growth of CNS mets in patients with EGFR mutation positive non-small cell lung cancer. Next slide, please. How does the efficacy of osimertinib compare to first generation TKI in the treatment of non-small cell lung cancer with EGFR mutation? Next slide, please. Now coming to the FLORA study, EGFR mutation positive metastatic non-small cell lung cancer osimertinib as first line. Patients with EGFR mutation positive advanced non-small cell lung cancer assessed for eligibility. Eligible patients were randomized, stratified by tumor EGFR mutation according to EGFR exon 19 or array 58R arm and race and randomized, and primary endpoint was assessed. Final analysis was done and osimertinib was compared with the comparative EGFR TKI and compared and progression-free survival and overall survival was studied. Majority of patients had metastatic disease with 35% having visceral mets and 21% having CNS metastasis. So PFS is a direct measure of the drug benefit in patients with known or treated CNS mets. Median PFS was 15.2 months versus 9.6 months. Osimertinib had significantly longer OS than comparator EGFR TKIs. At 24 months, 74% osimertinib versus 59%. At 36 months, 54% versus 44% were alive. Next slide, please. In FLORA trial, osimertinib demonstrated a superior systemic PFS benefit regardless of CNS disease activity at study NC versus EGFR TKI comparator. Next slide, please. Next slide, please. Median PFS was known or treated was better in CNS mets. Intracranial PFS was also more in osimertinib arm. Hazard ratio was 0.48 and CNS PFS was statistically significant with osimertinib versus the comparator arm. Next slide, please. Next slide, please. Patients with and without CNS trial anti-investigation assess CNS progression events were observed. Next slide, please. Patients continue to receive first-line trial the osimertinib versus EGFR TKI. You can see the first-line osimertinib may delay the need for subsequent therapies. 28% versus 9% continue to receive the first-line trial drug at 36 months. Next slide, please. Now coming to the real-world evidence of osimertinib with CNS mets. Next slide, please. Rapid intracranial response to osimertinib without radiotherapy in patients with harboring EGFR T790 mutation. Next slide, please. Just coming to the first case. Next slide, please. Next slide. The this was a under previous slide. Sorry, the 7-year-old woman who underwent right middle lobe resection of the lung because of an early stage non-small cell lung cancer 9 years ago. Multiple nodules emerged in both lungs, which was recognized as a recurrence, and EGFR mutation analysis identified the EGFR L858R mutation in exon 21. Gefitinib was administered as first-line chemotherapy for 2 years. After 3 years of cytotoxic drug regimens, erlotinib was administered as fifth dose chemotherapy. EGFR TKI rechallenged, which failed in 3.5 months. After 2 courses of vinorelbine, the patient complained of unbearable back pain and spinal MRI detected multiple thoracolumbar bone mets. Seventh line chemotherapy, osimertinib was administered. A rebiopsy was done with ratio T790 mutation. On day 5 after administration of osimertinib was started, a chest X-ray revealed shrinkage of right pulmonary nodule. CT images on day 13 revealed complete remission of brain mets except for one lesion in the left frontal lobe. Next slide, please. So this is the same thing. Next slide, please. So you can see the multiple metastasis at baseline, complete remission of brain mets except for one in the left frontal lobe after 13 days of osimertinib treatment, and shrinkage of the right pulmonary nodule after 5 days of osimertinib administration. Next slide, please. Case 2. Next slide, please. Next slide, please. A 76-year-old man with a 22.5-year pack smoking history underwent right upper lobe resection of the lung because of an early stage non-small cell lung 10 years ago. EGFR exon 19 deletion was present. Multiple bone mets as recurrence emerged. Gefitinib was administered as first-line chemotherapy. Afatinib was administered for 10 months after sandwiching 4 courses of carboplatin plus palmitoxin with bevacizumab. Fourth-line chemotherapy was being administered. Fluid refusal with right-sided dominance was seen. A thraicosynthesis was conducted and detected the additional mutation T790 mutation in exon 20. Osimertinib was administered as fifth-line chemotherapy when the ECOG PS grade was 2. Next slide, please. On day 10 after administration of osimertinib was started, brain CT revealed the remission of single brain mets in right parietal lobe, which was asymptomatic. On day 14, decrease of pleural effusion and shrinkage of pulmonary nodules were recognized. After a month, chest CT revealed shrinkage of multiple lung mets and decrease of left-sided pleural effusion. His ECOG PS gradually improved to on decrease of pleural effusion. Next slide, please. This is the day 10. You can see the complete remission of single brain mets after 10 days of osimertinib treatment. Next slide, please. You can see the chest CT and there is decrease of pleural effusion and shrinkage of pulmonary nodules. After 31 days, shrinkage of multiple lung mets and decrease in left-sided pleural effusion. Next slide, please. Case 3, complete remission of multiple brain mets in a patient with EGFR mutated non-small cell lung cancer treated with first-line osimertinib without radiotherapy. A 74-year-old with no history of smoking had an 4 centimeter upper lobe left lung and multiple small nodules in the entire lung field diagnosed with stage 4B lung adenocarcinoma with exon 19 deletion. More than 20 multiple asymptomatic brain mets were present. Osimertinib 80 mg was administered as first-line treatment. WBRT was deferred. Next slide, please. So you can see the shadows in the upper lobe of lung, multiple bilateral nodules in the entire lung field. Next slide, please. Complete CNS response was confirmed in the brain MRI, as you can see after the multiple brain mets which were present after 5 weeks. The multiple brain mets had completely disappeared. Next slide, please. Intracranial response of de novo brain mets treated with osimertinib alone in patients with newly diagnosed EGFR mutated non-small cell lung cancer. Next slide, please. So, retrospective cohort study, patients were selected from an institutional database if they had a diagnosis of EGFR mutated non-small cell lung cancer treated with osimertinib between 2014 and 22, received osimertinib alone as initial therapy after first brain metastasis diagnosis. At least one intact brain mets not previously treated with systemic or local therapy at osimertinib initiation had baseline brain magnetic imaging before and at least one scan after osimertinib initiation. Next slide, please. This is a pre-osimertinib scan 2 months after post-osimertinib regression of disease is observed. 34 months post-osimertinib disease control was seen until 34 months post-osimertinib. Next slide, please. There were 36 patients who had a median interval from brain mets diagnosis to first-line osimertinib initiation of 25 days. In 136 previously untreated brain mets, 77 had complete response and 31 had partial from baseline MRI. This reflects the best objective response rate of 100%. 2-year overall survival was 80%. CNS progression rates at 1, 2, 3 post-osimertinib were 21, 32, and 41. Local failure was estimated to be 0.7, 4.7 at 1 and 2 years post-osimertinib respectively. Next slide, please. What are the recent guideline updates suggest? Next slide, please. Next slide. So you can see the EGFR exon 19 deletion or exon 21, which is detected, and EGFR mutation discovered prior to systemic therapy. Then osimertinib is the preferred treatment, or along with chemotherapy, is category 1. Other combinations being erlotinib or erlotinib plus ramucirumab and EGFR mutation discovered during first-line systemic therapy. You can complete the plant systemic therapy or interrupt, followed by osimertinib. Progression, we can do subsequent therapy. Next slide, please. Thank you.
So thank you, Dr. Abhishek, for the excellent talk. So, is there any question to any another faculty? So, moving ahead for the next session, and I would like to invite Dr. Suman Mayur, and he's a deputy in charge medical oncology, Saroj Gupta Cancer Center and Research Institute, Havda, and to give us talk about how to proceed lung biopsy principle of molecular and biomarkers analysis. So it's over to you, sir.
A very good evening. Uh, I'll share my slides first. Is my slide visible?
Yes, sir. Is it possible? Can you please open your video?
My video, yes, yes. I'm keeping it open. Okay. So tonight I'm going to talk about the molecular biomarker testing in lung cancer. The major contents of my talk will be the incidence of lung cancer in India and the major biomarkers that we need to test in non-small cell lung cancer, and how the biomarkers evolved for testing the past scenario and the current practice, and key takeaways from the practice guidelines. The burden of lung cancer is pretty high in India. It is practically the fourth most common cancer overall, irrespective of the sex and age, after breast, deep and oral cavity, and cervix uteri. And in male, it is the second most common cancer. It is from the report of Globocan 2020. The 2022 report is almost similar, but the numbers are higher than those of the couple of years before. It is predicted that after a few years, like after 2025 or 26, the new incidence of lung cancer will be the highest among all cancers, especially due to the increase in the rate of incidence of cancer in the women, especially young women, harboring more and more adenocarcinoma, irrespective of their smoking pattern. And the lung cancer, the scenario of lung cancer will be pretty grim within a decade. So talking about lung cancer will become very important in coming years. If we deduce the uh, uh, relative percentage of incidence of oncogene mutations in lung cancer, especially non-small cell lung cancer, with who are having adenocarcinoma in their histopathological examination, we can see that the most of the oncogenes that are mutated is KRAS and EGFR. Practically, EGFR is the most common till now, and in India, KRAS might be the second most common actionable gene mutation, followed by ALK, and the others are MATE, HER2, ROS1, BRAF, RATE, NTRK, PIK3, and MAKE1. From this chart, we can make sense that which drugs can be used against all of these mutations, each of these mutations. And we see that for EGFR mutation, the most common drugs are used in form of first generation drugs like gefitinib and afatinib, uh, gefitinib and alutinib, second generation drugs like afatinib and dacomitinib, and third generation drug like osimertinib. And for ALK mutation, we have first generation drug like crizotinib or ceritinib, but alectinib, bigatinib, and mostly lorlatinib might be more effective in ALK mutated lung cancers. And in RAS mutation, we do not have a very good drug combination except for the G12C mutation. Sotorasib and adagrasib can be used. For EGFR exon 20 insertion mutations, amivantamab and mobocertinib are the drug of choice. For MATE exon 14 mutation, capmatinib and tepotinib are the drugs. For HER2 mutation, we do not have any first-line drug. In second line, we can use trastuzumab deruxtecan. For ROS1 mutation, we can use crizotinib or entrectinib. For BRAF mutation, for V600E mutations only, we can use dabrafenib, and for rate mutation, we can use selpercatinib or pralsetinib. For NTRK mutation, we can use entrectinib or larotrectinib. So these are drugs, and this is a incidence of mutations in non-small cell lung cancer. So why do we think so much about these mutations? Because we need to do the testing for the mutation of non-small cell lung cancer, especially in the adenocarcinoma or the squamous cell carcinoma, who have never smoked or who are the incidence of the cancer, if it is in an early stage or the patient has very low smoking habit. So we should do this actionable gene mutation tests so as to give the patient a better chance to survive, because with targeted therapy against the actionable gene mutation, we see that median OS is pretty high than the non-targeted therapy. To compare it, it will become 18.6 months in comparison to the non-targeted therapy, which is 11.4 months, and the significance is very high. The p-value is less than 0.001. So it is a mandate to do all the mutation tests for advanced non-small cell lung carcinoma to offer the patient survival benefit in form of PFS and OS. As for the NCCN guideline, we need to do all these mutations: EGFR, ALK, ROS1, BRAF, MET, RET, NTRK, KRAS, and PDL1 tests. And as per the ASCO ISMO guidelines, they are a bit more conservative. They are planning to do EGFR, ALK, ROS1, BRAF, and NTRK mutation, and PDL1 expression in most of the cancers who are not expressing any gene mutation. So what should be the methods to test the actionable gene mutation for non-small cell lung cancer? The major tissue testing methods we use are DNA sequencing or through NGS or PCR, or we can do RNA sequencing panel, or we can use IHC or FISH testing. We'll discuss in details later that which test should be based for which mutation. As to start with, the DNA sequencing, they detect insertion, point mutations, and deletions, and for RNA sequencing, they use to detect fusion abnormalities, and FISH or any other in situ hybridization tests. They detect ALK or ROS1 tests. These are specialized testing. We need to keep in mind that EGFR testing, previously we used to do these tests in series of schedule. We used to do EGFR first, and if EGFR comes to be negative, then we proceed to ALK or ROS testing, because we had very few options in those times, and the testing was also very costly, and the TAT was high. So initially we used to do the EGFR only, and if the patient doesn't have EGFR mutation, then we proceed to ALK or ROS mutation or any other mutations. But nowadays, as we have this NGS testing panel, which is a high throughput test for multiplex genes, we can do all the genetic tests at one shot. But I think in a country like ours, which is a developing country, and people really have some uh, budget constraints, we can still do the EGFR test first, and then we can shift to the other tests, because the anti-EGFR first and second generation drugs are quite cheap. But if the patient wants to get the best of the therapies, then we must not delay the testing with a sequence of tests. Uh, this is mostly because the EGFR and ALK mutations and KRAS mutations, these are mutually exclusive mutations. So a patient, if the patient comes to be EGFR positive, it is very rare to have another ALK mutation or RAS mutation or others like HER2 mutation. So from past, how we have evolved to the present practice of testing. Previously, we used to do only histopathological tests, but these are still the gold standard of test to diagnose the histopathological nature of the disease. We used to dissect, excise, or take small tissue biopsies and put them to FFP block. This is formalin fixed paraffin embedded block. And from that, we proceed to further tests like immunohistochemistry to diagnose whether this is a non-small cell or to a small cell, or what type of non-small cell carcinoma it is, because the pattern of outcome and some treatments, especially chemotherapy treatments, might differ among the types of the disease. Like adenocarcinoma should differ from the squamous cell carcinoma, or we have non-small cell lung carcinoma. In ways, we can have a mixed tissue pattern like adenosquamous carcinoma. So we need to do the histopathology first. We need to confirm it with IHC, and then we proceed for the further tests with the modern testing methods, like I have said, DNA, RNA, and the proteomic tests. We can take the sample from FNSC also. The FNSC yield is not that high for testing the actionable gene mutation. We need to have a FFP block for sure. But apart from FFP block, we can do the histopathological tests and this gene mutation study from liquid biopsies, like from blood or any other fluids, to check for the gene mutation through circulating tumor DNA or cell-free DNA load. We can have the tissue sample also from exfoliative cytology, from urine, ascitic fluid, pleural fluid, sputum, CSF, and any other residual supernatant from other body fluids. So as I've said that we need to subtype the tumor, whether it is squamous or non-squamous, or whether it is a mixed type, or whether that the patient needs further gene mutation tests, because usually we go for the actionable gene mutation tests only to the patients who are suffering from adenocarcinoma or with squamous cell carcinoma, who are young, less than 50 years of old, 50 years age, or who are never or light smokers, or if the biopsy specimen is of mixed histology, that is adenosquamous type. And the tests can be of 12 or 13 gene panel, or separately EGFR, ALK, ROS1, BRAF, NTRK, RATE, MET, HER2, and PDL1 tests. The most important thing is that how fast we are going to have the diagnosis, because we cannot keep the patient waiting for long time to have the reports come and to start the treatment with which the patient might benefit the most. So turnaround time should be the least for the tests. For circulating tumor DNA testing, the test has become quite a popular one in these days, especially the patients who are having very less probability of getting tissue harvested due to age or comorbidity or any other contraindication. So we can take a blood sample or any other fluid sample to detect the mutations through circulating tumor DNA. It is not the gold standard of testing. The current guidelines still tell that if the ctDNA shows that there is no mutation, we still need to try to harvest tissue from the body and go for another cycle of genetic testing. But if it comes to be positive, it is a very highly sensitive test. If it comes to be positive, then we can rely upon it. So it has a complementary role in diagnosing the genetic mutations in lung cancer. We see with the TRISADEX study that ctDNA can complement to the diagnosis of residual tumor after a curative surgery. The minimal residual disease can be diagnosed well with circulating tumor DNA. We see that 93% of patients with disease recurrence were MRD positive tested by ctDNA, and 90% of the patients without the recurrence were MRD negative. So it has both positive and negative predictive value. So to compare the tissue biopsy and liquid biopsy, we can say that the sample acquisition is easier for the liquid biopsy, and we can take repeat sampling in the lifetime of the patients more than once, or to detect the further gene mutations during or after the treatment. So repeat sampling is easier for liquid biopsy. For biology, we see that tumor tissue harvesting has a better edge over liquid biopsy because it has more correlation with the histology and cellular phenotype. The sensitivity is very good for liquid biopsy, but the test methods should also be very sensitive to harvest the gene to detect the gene mutation, because only less than 0.1% of the cell-free DNA has circulating tumor DNA. For analytic standardization, we see that tumor tissue is a gold standard for testing the gene mutations, and the evidence is more for the FFPE blocks to test the gene mutations. As I've told previously, that the optimal sequence of testing might be EGFR, ALK, and other genes, which was the usual practice previously, because we used to do single gene testing through different singleton methods. But with multiplex high throughput method like next generation sequencing, we can do a successful test over multiple genes at a time. So we can do EGFR, ALK, ROS1 MET, and all other gene mutation tests in one go these days. So actually, current ESMO guidelines, they tell that NGS has a better edge over single gene testing in case of detecting a gene mutation of lung cancer. So again, we see that if we test a single gene, then the traditional methods have advantage both in terms of cost and turnaround time. But if we want to test multiple genes, then NGS has obviously advantages over the sequence of many single gene tests. This is quite a busy slide. The summary is that we need to test these genes mainly, and the most common genes are following. EGFR, we need to test EGFR exon 18, 19, and 21 mainly. And the most common mutations are EGFR exon 21 in form of L858R and EGFR exon 19 mutations. The less common mutations are G719X and L861Q mutation. For the former one, we should use third generation TKI in form of osimertinib. For new onset T790 mutation during the treatment, we should again use osimertinib. But for less common mutations, afatinib is the first choice of drug, and we can also use these drugs along with chemotherapy as per the current FLORA trial. Our previous speaker has spoken a lot about this trial. For KRAS mutation, the G12C mutation is actionable. We can use drug against it. And for MET mutation, the exon 14 mutation is most common, and the others are skipping mutations, overexpression, and amplifications. ALK fusion are actionable. For BRAF, V600E mutation is most common to take into account. For ROS1 mutation, fusions are most common. For rate, KIF5B mutation is the most important mutation, and other point mutations might be there. NTRK mutations are gene fusions with NTRK1, 2, and others. HER2 mutation, usually we have exon 20 insertion mutation, and there might be some other minor mutations in this. Overall, P53 mutation is the most common mutation apart from these actionable gene mutation, but we do not have anything to do with P53 mutation. But I think the lipid lowering agents might prove beneficial if the patient is having a P53 mutation. So for EGFR mutation, we see that there is a very good correlation between the primary tumor and the metastatic tumor, and we can harvest from either one to get the EGFR mutation done. For early lung cancer, there is also a role of testing the EGFR mutation, as we have got the ADAURA trial. The ADAURA trial shows that we should use osimertinib in adjuvant setting for EGFR mutated lung cancer after the patient gets definitive therapy done. For ALK rearrangements, we see that the FISH test is most important. The false positive rate is only 0.1%. ISC is less expensive and hence more widely adopted, but I think FISH should be done, or an NGS is the best choice. For ROS1 rearrangement mutation, we should detect again ROS1 through IHC and FISH, but FISH is the confirmatory testing. But IHC is a cheaper one, so we can screen the patient for ROS1 through IHC, but whenever IHC comes to be positive, we need to confirm it by a FISH test. For KRAS mutation, it is again it is a part of EGFR RAS MEK ARC pathway. For KRAS mutation, the G12C mutation is actionable, as I said, and KRAS mutation is also mutually exclusive with EGFR and ALK mutation. And in India, the incidence of KRAS mutation is a bit high, but using adagrasib or sotorasib, I haven't used it previously, but I think in very near future we'll be able to use it and have the benefits. For BRAF mutation, V600E mutation is more than 50% of the BRAF mutations, and a combination of dabrafenib and trametinib is the drug of choice. Trametinib is actually the MEK inhibitor. We should use it together to the BRAF inhibitor. For c-MET mutation, it is the major mutation is through the exon 14 skipping mutation, and it is seen in the 3 to 4% of non-squamous non-small cell lung carcinoma, and in 20% to 30% of sarcomatoid cancers. Here, FISH or IHC, neither of them are recommended. Only DNA or RNA NGS are used, but RNA-NGS is more sensitive. For rate receptor tyrosine kinase mutation and rate fusion mutations, these are actually seen in non-squamous lung cancer in a very low incidence, 1 to 2% only, but it can be seen in main 2 medullary thyroid carcinoma, or 20%, 15% actually of papillary thyroid carcinoma. And the KEAP5B mutation is most common. And for rate, we can use IHC, FISH, DNA NGS, RNA NGS all together, but we should do RNA NGS. This is the choice of method for this test. For NTRK fusion, we should again use RNA NGS, which is more sensitive. And this is the comparative study of IHC, FISH, and NGS. As I've told that NGS has the potential for multiplex testing, and we can have the report altogether with the other gene mutations. For HER2 mutation, we can have HER2 mutation mostly with exon 20 insertion mutation in 3 to 5% of non-small cell lung carcinoma. And HER2 mutation actually has worse ways. It is not actually actionable in the first line. We should use chemotherapy only, and if the patient progresses with chemotherapy, HER2 mutations can be acted upon by this in-HER2 drug. With HER2 mutation, the CNS complications are more common. CNS paraneoplexus syndromes are more common. So for advanced non-small cell lung carcinoma, what we have, these mutations, I've spoken about them in details previously, and these are the drugs that are actionable, that act upon these gene mutations. So classical deletion 19 or L858R exon 21 mutation in EGFR, we can use osimertinib. This is the preferred drug. Apart from that, erlotinib or afatinib can be used. Afatinib being a pan-EGFR inhibitor, it has more side effects in form of dermatological side effects or GI side effects. The uncommon mutations should be acted upon by afatinib. Osimertinib also can be used. And as we have already learned from our previous speaker, that osimertinib really has a very good advantage in preventing or in treating the CNS disease, CNS metastasis. In exon 20 insertion mutation, amivantamab or mobocertinib is a drug of choice. For ALK mutation, we should use alectinib in the first line, but I have seen many patients surviving for a long time with crizotinib. But lorlatinib, the trials are showing extraordinary results, so lorlatinib might become the drug of choice in near future. ROS1, crizotinib or entrectinib can be used, and for BRAF mutation, dabrafenib and trametinib combination should be used. Entrec, entrectinib or larotrectinib. RAID mutation, we can use silpacatinib or rasatinib, and MET mutation, we can use capmatinib or tepotinib. And for KRAS G12C mutation, we can use sotorasib. PDL1 is another important protein that needs to be checked. But most of the patients who are having an actionable gene mutation and immunotherapy doesn't work well. So if the patient is not having actionable gene mutation, then we should use immunotherapy in the first line. And in many trials, we have seen that the drugs, actually the immunotherapy drugs, can work well irrespective of the PDL1 status. But if the PDL1 is pretty high, like if it is more than 50%, then a single immunotherapy might prove to be very beneficial. The PDL1 testing clones platforms are these. We usually use DACO platform for pembrolizumab and nivolumab. And for pembrolizumab, we use 20C3 antibody clone, and for nivolumab, we use 288 antibody clone. And in Ventana platform, which is used for atezolizumab and durvalumab, we use SP142 and SP263 antibody clones respectively. This is the pattern of antibody expression. So PDL1 currently is the sole biomarker to guide immunotherapy, especially for the non-small cell lung cancers. Tumor mutation burden can be used as a proxy marker in some cancers, like in GI cancers mainly. MSI high or deficient MMR is not used in lung cancer, but in many other cancers like breast cancer and other cancers, GI cancers, we can use these as a marker, whether to use immunotherapy or not. LAG3 possibly may be used in diagnosis of resistance to immunotherapy and is under study. So what is our conclusion? It is that biomarker testing in non-small cell lung carcinoma has evolved from single gene to multiplex testing, and it can be done to a high throughput testing method like next generation sequencing, which has a very low turnaround time, which is as low as 10 working days, 10 to 14 working days actually. And samples should contain adequate tumor content to prevent delay in processing. And I should add that all samples should be tested for histopathology as per the WHO 2021 guideline. And multidisciplinary meetings are to be held to better understand the sample and test requirements. And NGS should be used wherever it is financially or technically feasible to detect the actionable gene mutations. And the testing methodologies are these. For EGFR mutations, we can use PCR or NGS. NGS can be used for everything. For BRAF mutation, we can use PCR or IHC. For RAS, we can also use PCR, but FISH is mandated for ALK, ROS, or RATE. And NGS is actually mandated for other gene mutations like NTRK, MATE amplification, or MATE exon 14 skipping mutations. So this is the actually everything for the osimertinib product monologue is here in nutshell, and no need to describe it. So thank you. That's all for tonight.
Okay, thank you so much, Dr. Soman. Is it any question? So moving ahead for the next session, and thank you so much, Dr. Soman. So I would like to invite Dr. Shea Malik, and she's a consultant medical oncology, Dexon Hospital, Kolkata, and to her give us talk about overview of lung cancer. So it's over to you, ma'am.
Good evening, everyone. So, can you please share the screen for me?
Yeah, sure, ma'am. Just wait. Is it visible?
Yeah, sure. So, My topic of discussion is, should I start now, right? So today's topic of discussion is overview of lung cancer. All of you know it is a vast topic and most of the things are already covered by my previous two speaker nicely. So I'll be very short and crisp for the discussion of as a generalized way. So you know the burden of the lung cancer in India. It is a data of Global 2020, but recent 2022 data is like similar on everything. Just the total number incidents and mortality has increased. And if we see the scenario in males, it is the second most common cancer after the lip and oral cavity cancer. Next slide. So if we see the mortality also, the lung cancer is an important cause of death in India due to cancer. Next slide. Next slide. So it is a staging. Initially, we used to have AGCC 7th edition, then we had 8th edition, and now we have 9th edition also recently. But the major change which came into place from 7th to 8th edition, which is inclusion of the T3 tumor that is a more than 7 centimeter, which was initially under 2B, it is now under stage 3. Next slide. So it is a basic thing how to diagnose a lung cancer. So it depends upon when the patient is presenting to you. So initially we do a chest X-ray. Definitely the patient comes from a rural background or some general practitioner. They do a simple chest X-ray, and if something is abnormal, they just send to a higher center or any oncologist. So CT scan primarily done, and depending upon the CT scan finding, we can go for a bronchoscopic biopsy or CT guided biopsy from the lung mass. And nowadays, PET CT is essential and mandatory for the lung cancer staging. And MRI brain, depending upon the symptoms, and the EBUS or UEUS or mediastinoscopy that we will come later on. So these are the optional and depends upon the clinical scenario which requires the test or not. Next slide. So why PET-CT is important, especially for staging in stage 3 non-small cell lung cancer, because CT scan has a limited sensitivity and low specificity. But if we add the PET's nuclear scan along with the CT scan, we just get the increased sensitivity to 80 to 9% and the specificity up to 85 to 95%. And one more thing, the lymph node, which is more than 1 centimeter in short axis, that indicates the malignancy. And if we get a CT scan picture with a lymph node mass of more than 1 centimeter, there is a role of PET CT because it sometimes tell the SUV also whether to take it seriously or not. Next slide. So same thing where there is a confusion, that is a clinically N2 stage, that is a occult N2. When we will just focus on the N2 because it is a criteria for a resectability. So it has been shown in different studies that the centrally located tumor, and it varies with the in occult N2 positivity. That is, in the study, it has been shown that the centrally located tumor has a more chance of getting the occult node level N2 positivity, along with the size of the tumor. If the tumor size is more than 3 centimeter, as you can see in the uppermost left table, there is an increased chance of having the occult N2 disease. And yes, there is, if there is a PET-CT SUV uptake is on the higher side, especially more than 4, that is a chance of positivity of the occult N2 disease. Next slide. So there is a lot of discussion about the mediastinal staging, whether to go for not or how to approach. So we have mainly two options, that is endoscopic EUS, endoscopic or endoscopic ultrasound biopsy, or invasive methods. We have mediastinoscopy, we have VATS, we have VAMLA, we have TEMLA, etc. And along with that conventional method also. Next slide. So it is a very busy slide, but the thing is, recommended technique for the mediastinal staging is EBUS or EUS, but many centers do not have this EUS facility. That is a problem, but it is a standard of we should prefer for a non-invasive technique. If there is highly strongly suspicious of the N2 nodal 2 involvement, and even we get the negative report in EWATS or EUS, then we should proceed with the surgical staging with a mediastinoscopy. Next slide. So when we require the invasive mediastinal staging by mediastinoscopy, if there is the tumor is located centrally, if the tumor size is more than 3 centimeter, if there is extensive infiltration of the mediastinum with no evidence of extrathoracic disease or positive N1 disease, or there is bulky N2 on CT scan, there is no need for invasive confirmation because it is already bulky, it is in radiological proof. And if there is discrete N2, yes, if there is PET-CT, whether the PET-CT reports positive or negative, we should go for a mediastinal staging. Next slide. So it is the same thing which I have discussed, when to proceed for mediastinal staging and how to proceed. In a nutshell, if we plan for a surgery, we should look for the N2 involvement because it is a criteria for unresectability. Next slide. So it is also the same thing, there are multiple lymph node stations, as we know. So there are this process, these are there to determine the lymph node station. And as you can see, EBUS or US, it is a most convenient for most of the stations, but definitely the invasive one, if we can go for extended mediastinoscopy, we can just approach to many of the lymph node, which is difficult with the EBUS technology. Next slide. So it is the same thing already discussed. Next slide. So there is evolution of therapy in lung cancer. It is already quite extensively discussed by my previous two speakers. So just in a nutshell, NSCLC, we just take it a systemic disease. So from early stage to extensive stage. And nowadays we have molecular classification, not only histopathological classification, and we have a era of precision medicine. So right therapy for a right patient. So that's already discussed by the Dr. Shoman, that how to proceed with the all the molecular testing. And most importantly, we should go for the molecular testing in all non-small cell lung cancer, and we should do at baseline, and we should not go for all the sequential testing. So initially we had non-small cell and small cell variant. Later on we had among non-small cell, we have large cell adenocarcinoma, squamous cell carcinoma. Then came into picture with EGFR L-cross, and now we have option of immunotherapy. So we should do the PDL1 testing also, and along with the tumor mutational burden. Next slide. So it is also the same thing. It is definitely the advances in management of non-small cell lung cancer has improved the survival. The survival from 2001 to 2014, and now we are in 2025. Definitely, we have a very good survival in last 10 to 15 years with the help of the targeted therapy. Maybe it oral targeted therapy, oral TKI, maybe it is any monoclonal antibody, maybe it is a immunotherapy. So all this therapy, when in many studies and most of the studies, when compared with the conventional therapy, this increase the survival. Next slide. So it is a year-wise development of the targeted therapy. Initially, we had chemotherapy, and initially, along with chemotherapy, we used to have bevacizumab. Later on, there came into picture the platinum and pemetrexed, and when the ALK positivity was discovered, crizotinib was started in use in 2011, and gradually arlotinib, gefitinib, and again Crizotinib for ROS positive NSCLC in 2016, and pembrolizumab came into picture in 2016 with in a single agent pembrolizumab with a PDL1 positivity of more than 50%. And now it is 2025. So in this chart, it is already mentioned in only up to 2020, but in last 5 years, we have progressed a lot. It is not mentioned in this chart, but as of all of you know, not only the non-small cell, even small cell also, we have approval for the immunotherapy. And many drugs are getting approved in every month. Like the change of therapy, the therapy is changing every day. So we have to be updated and we have to give the patient as per patient choice. So precision therapy, like right patient to right treatment. Next slide. Next slide. Yes. So it has been already discussed. Just one thing, that is there are now 7 molecular alteration with FDA approved targeted therapies. So we have therapy for EGFR mutation, we have therapy against ALK and ROS1, we have therapy against BRAF V600E, we have therapy against NTRK, MET exon 14 and RET. So as we have therapies against this alteration, we should go for the molecular testing in the at diagnosis only. Next slide. So it is a guideline on neoadjuvant adjuvant chemotherapy dependent on the disease stage and finding. So definitely if it is stage 1, it is a observation is preferred because there is no benefit of the chemotherapy. In stage 1B or 2A resected stage, there should be, and definitely in lung cancer treatment, we should have a multidisciplinary tumor board for every patient. And so there is no role of neoadjuvant chemotherapy in stage 1B or 2A, but there is some role of high-risk patient with adjuvant chemotherapy. And if there is a patient of stage 2B where there is N1 lymph node is there, definitely adjuvant chemotherapy is recommended. And again, there is no role of neoadjuvant chemotherapy. And if it is not resectable, then we can go ahead with the concurrent chemoradiotherapy. And if it is resectable stage 3A, then there is a role of neoadjuvant chemotherapy, and definitely we should offer the patient with the adjuvant chemotherapy. Next slide. So again, it is a adjuvant treatment because of the margin. So resection margin as well as the pathological stage, both are important for the decision of the adjuvant treatment. So if there is negative margin, so it's having a good outcome. And it may be R1 resection like microscopic positive margin or Ross residual disease with a R2 resection. So if we see the chart again, if there is stage 1 or 2A, observation is a better option. And for high risk patient, we can go for like stage 1B or 2A high risk patient. We can go for, if R1 resection, we can prefer resection, but that is not a feasible option in our Indian patient. We can go for the adjuvant radiation. And if it is stage 2B with N1 lymph node, again, there is a complete resection, R0 resection, adjuvant chemotherapy is required. And if it is R1 or R2, we can discuss the patient with the resection plus chemotherapy, or we can give the sequential concurrent chemoradiotherapy. And if stage 3 is 3B, then R0 resection, adjuvant chemotherapy is a must. And or there is sequential chemotherapy or radiation therapy in two diseases. And if R1, R2, definitely there is concurrent chemoradiation. Next slide. So after initial treatment in non-metastatic stages, more than half of the patient of resectable non-small cell lung cancer experience recurrence within 5 years. So in a study, it has been shown that 40 to 50% patient are cancer free, but 50 to 60% recur in a form of local or distant recurrence. Next slide. So it is a ESMO guideline which recommend that the adjuvant chemotherapy is recommended in patient with resected stage 1B disease and with a primary tumor of more than 4 centimeter. Due to it is a clear benefit of chemotherapy. So in the left hand curve, it is a stage 1B tumor, but the tumor diameter of less than 4 centimeter, where it is clearly visible that observation is better than giving chemotherapy. But if stage 1B with a tumor diameter of more than equal to 4 centimeter, then obviously there is a role of chemotherapy over observation. Next slide. So it is a age-old meta-analysis. All of us has already studied it. So less meta-analysis, it is a overall survival benefit from post-operative cisplatin in early stage non-small cell lung cancer. And we know that there is a absolute benefit of 3.9% and 5.4% at 3 and 5 years chemotherapy versus observation. Next slide. And in the less analysis, the cisplatin vinorelbine, the most commonly chemo was used. So it is also the same thing that we have discussed. It is regarding the neoadjuvant chemotherapy. About the adjuvant also, for stage 1B or 2A neoadjuvant chemotherapy in this meta-analysis, hazard ratio was 0.87, and in adjuvant chemotherapy, it is hazard ratio is 0.89. Next slide. So this trial also already discussed, but again, the thing is targeted therapy. It is not that we can use the targeted therapy in only in the advanced stage. It is now moving into early stage also. In ADORA trial, there is a clear improvement of the DFS with osimertinib in resected EGFR mutation positive non-small cell lung cancer. So in this trial, there was inclusion of the stage 1B, 2 and 3A EGFR mutation positive lung cancer, which were completely resected. And the patients were divided into two arms with osimertinib or placebo. And there is, if we use the osimertinib drug, then there is an improvement of the DFS from 44% in the placebo group to 90% in the EGFR TKI arm at 2 years. Next slide. Next slide, please. So again, the immunotherapy also coming into picture in adjuvant setting. So in this trial, it has been showed that improvement of DFS as well as OS in the adjuvant setting in patient with PDL1 more than 1%. So what we have already discussed, that is the thing is in resected non-small cell cancer also, there is a chance of recurrence within 5 years in a population of around 50%. So nowadays we have many adjuvant therapy like in terms of osimertinib or immunotherapy to get a better long-term survival. Next slide. So I'll not go into details of the radiation. So as we know, nowadays we are using IMRT technique and it increases the survival for the patient of stage 3 NSCLC and T3, T4 tumors. And because we need to reduce the dose to the heart and we need to reduce the pneumonitis, grade 3 or more pneumonitis. So next slide, please. So again, it is SBRT. So what is the difference between conventional RT and SBRT? So SBRT, we know it is a high dose per fraction, typically 8 to 20 grade per fraction, and it usually hypofraction. There is a 1 to 5 fraction with definitely 3D technology. But it can be used in early stage NSCLC, but it cannot be used, but it is difficult to use if the tumor size is more than 5 centimeter or there is a involvement of the nodal into disease. Next slide. So what are the new things in 2022? So from 2022, now we are at 2025. In last 3 years also, many new technologies in radiation came into picture. But as of now, we have 4D CT planning. We have image guided radiation therapy. So we can reduce the margins needed to cover the tumor. If we can reduce the margin, we can definitely avoid the toxicity to the normal organ. And we have a feature of adaptive radiation. So it is a new radiation planning after tumor target volume had reduced in size. So we have to plan accordingly. The tumor is reducing in size. Next slide. So it is a result from RTOZ 0617. So it has been shown that if we can increase the dose, so it is so in this study we have used the standard dose versus the high dose chemoradiation plus minus cetuximab in stage 3 or stage 3B non-small cell lung cancer. So definitely the result was 5-year overall survival around 32% with high quality standard dose RT, and there is no role of RT dose escalation, and there is no benefit of cetuximab addition. So the crux is there is a standard dose radiation without dose escalation and without addition of the cetuximab. Next slide. And definitely stage 3 non-small cell lung cancer is a curative disease if we correctly choose the correct treatment for the correct patient. So it is a chemotherapy with or without radiotherapy in the standard of care for the completely resected patient with stage 3 NSCLC. It has already been discussed. So next slide. So it is already discussed specific trial. So it is a immunotherapy in stage 3 unresected non-small cell lung cancer. It is showed that definitely there is a benefit of durvalumab in unresectable non-small cell lung cancer after definitive CTRT. Next slide. So it is a data that it increases the demonstrate the 42.9% overall survival at 5 years. And if we compare the historical overall survival in unresectable stage 3 non-small cell lung cancer at 5 years, it is 15 to 25%. So definitely durvalumab has a increased overall survival at 5 years post definitive CTRT. Next slide. So it is a era of targeted therapy and immunotherapy. So we have already discussed the which targets we should look for, and immunotherapy we should do a PDL1 at baseline. Next slide. So 50% of the patient with advanced squamous non-small cell lung cancer will have a driver mutation targetable with a FDA approved agent on a trial, but definitely in Flora trial, PFS with first line osimertinib, as we know, there is increased PFS with osimertinib if we compared with the first line conventional EGFR TKI with a median PFS of 18.9 months versus 10.2 months in the first generation conventional EGFR TKI. And if we see the ALK positive non-small cell lung cancer, initially crizotinib was there, but nowadays we have a very good data for lorlatinib also in the first line with the ALK positive NSCLC. Next slide. So other emerging the drug for the other targets. So it has been already discussed. So we have therapy for MET exon 14 alteration, rate rearrangement, NTRK rearrangement, and HER2 mutation. But for HER2 mutation, we don't have any first line therapy. We have arotrastuzumab emtansine in the second line therapy. Next slide. So it is a busy slide. So in the right hand side, we can see the name of the trial. So the basic thing is there is an increased survival rate with if we compare with the conventional chemotherapy, there is definitely improved survival with lesser toxicity if we compare with the conventional chemotherapy. So EGFR, ALK, rate, NTRK, ROS1, BREF. So we have a PFS of almost more than 12 months in each and every drug, as you can see. But in conventional chemotherapy, it is like 4 months, 6 months, and it's like so it is a significant improvement of the survival in targeted therapy, any of the targeted therapy. Next slide. Next slide, please. So I'll not go into details. All of you know the mechanism of the immunotherapy. It is we have to use our immune cell of our own body to fight the cancer. Mainly we have CTLA4 blockade or PD1, PD-L1 blockade. Next slide. So it is a year-wise picture of the development of the immunotherapy over time. So in 2015, pembrolizumab was approved for second line, and 2016 only it was approved in first line as a single agent if the PDL1 TPS score is more than 50%. And later on, so there was approval of the estrozolizumab in first line for non-squamous non-small cell carcinoma with along with the carboplatin, paclitaxel and bevacizumab in 2018. And in 2018 only came into picture durvalumab that we have discussed, unresectable stage 3 non-small cell lung cancer, where there is without progression after concurrent chemoradiation. And now 2021 there is semipilimab in first-line metastatic non-small cell lung cancer or locally advanced non-small cell lung cancer eligible for resection or definitive CRT with a PDL1 TPS score is more than 50%. And again, from 2021 to 25, we have a lot of drug in multiple indication that is not covered in the slide. So next slide. So survival outcome as already discussed. So not only the PDL1 status, so depend upon the PDL1 percentage. If it is more than 50%, there is an option of using single agent immunotherapy. And if it is less than 50%, we can combine the immunotherapy along with the chemotherapy, and we can use the targeted therapy as bevacizumab along with the immunotherapy and chemotherapy. So on all categories, you can see there is improvement of the survival, both the PFS and OS in all the immunotherapy agent. Next slide. And just one thing, you have to divide the histology with squamous or non-squamous, and accordingly we can use the immunotherapy drugs. So definitely checkpoint inhibitors have improved survival in advanced non-small cell lung cancer. And it is a keynote 024 study which showed that there is an improved survival in patient with pembrolizumab compared to the chemotherapy if the PDL1 TPS score is more than 50%. Almost 32% patients were alive at 5 years with the use of immunotherapy in metastatic non-small cell lung cancer. So definitely, as we know, the stage 4 non-small cell lung cancer patients are generally not that much fit. They are usually performance status is poor. So they may not be a fit candidate for chemotherapy, but if we can do the PDL1 testing, they might be a candidate for immunotherapy. And if there is a TPS of more than 50%, there is an excellent response with the single agent immunotherapy. Next slide. So there is a multiple ongoing trial in adjuvant setting also with immunotherapy. So it is under trial. So results, most of the trial yet not published. So we have pembrolizumab and durvalumab, nivolumab and atezolizumab in the adjuvant setting with or neoadjuvant therapy also. Next slide. So we know that we have antibody drug conjugate therapy approved in breast cancer, multiple drugs, but in non-small cell lung cancer, there is upcoming trials with ADC. So that will be published soon. So next slide, please. Next slide. It is not that much relevant. So in conclusion, uh, as because my topic was overview of lung cancer, it is a huge thing. So the thing is, the management landscape is first changing. Every day we are getting a new approval or a new drug in a different stage and everything. So we have to be updated, and newer therapies and a huge potential to improve survival, because we know that the lung cancer is a systemic disease, and conventionally we had a idea that chemotherapy, the average lifespan will be like 8 to 12 months, but nowadays with the advent of targeted therapy or immunotherapy, the quality of life of the non-small cell lung cancer advanced stage is improved along with the survival also. So not only the squamous, it is squamous, adenosquamous, adenocarcinoma, all the subtype, all the clinical subtypes or histological subtypes has a good overall survival benefit with the use of immunotherapy. And molecular alteration, we should do the molecular testing at baseline, not sequentially at a single go. And at least if the affordability is not an issue, we should go for a comprehensive genomic panel. If affordability is an issue, we should go for at least 7 markers. And why we are preferring the targeted therapy? Because there is a logistic benefit also. The patient always prefer to take the oral pills over the injectable chemotherapy, and patient usually avoids coming regularly to the hospital. So the logistic benefit, safety profile, and the survival and the quality of life, all these are beneficial if we can go for any targeted therapy. And one more thing, because the lung cancer patient directly do not come to the oncologist, so they come via the pulmonologist or the physician. So the pulmonologist or the physician should have a good knowledge about how to diagnose the lung cancer in an early stage. So thank you very much. And if there is any question, I'm happy to answer it.
Thank you so much, Dr. Shreya. Is it any question? So, moving ahead for the last session, and I would like to invite Dr. Deva Jyoti Maji and consultant medical oncology Denton Hospital, Kolkata, and to give talk about advanced EGFRM and SCLC, evidence-based review of targeted therapies. So, it's over to you, sir.
Thank you. Can you please share the slides? Good evening, everyone. I'm Dr. Devayoti Maji, and thank you, AstraZeneca, for giving me this opportunity for this presentation. Today, I'll discuss about the management of advanced EGFR positive non-small cell lung carcinoma based on the different targeted agents, specifically focusing on osimertinib. So, epidemiology-wise, in globally, as per 2022 data, lung cancer is the second most common cancer diagnosed in males and third most common in females, and it is the most common cause of cancer-related death in males and females. And India, it is the fourth leading cause of cancer-related death, and it is fourth most common cause of cancer incidence-wise. As you can see, about 5.5% of all cancer are because of the lung cancer. So non-small cell lung cancer, it is the most common variant of lung cancer in India. Next, please. Next slide. Okay, as you can know, all the survival of lung cancer is very dismal, and it depends on the stage. As you can see, the stage-wise diagnosed case is almost most of the around 65 to 70% of the cases are diagnosed in stage 4, whereas 30% cases are diagnosed in stage 3, and early stage diagnosis is only less than 5%. And the 5-year OS depends on the stage. As you can see in the first stage 1 and stage 2, the 5-year overall survival rate is around 80 to 90%. whereas in stage 4, it is less than 5%. So if we diagnose the cases early, better is the response result. And more than 50% of the advanced non-small cell lung carcinoma has some biomarkers. The biomarkers can be divided as a predictive biomarker or prognostic biomarker. Predictive biomarkers are those which are indicative of certain which have some therapeutic benefit. Based on these markers, we can give some targeted therapies. Whereas on the prognostic marker, it indicates the survival or the overall result of the disease, irrespective of treatment used. So, as of now, almost all stage 4 lung carcinoma, we advise genetic testing along with PD-L1 testing. Most commonly, we advise NGS-based testing, although the PCR or IHC-based testing can also be applied. So overall, worldwide, most common the genetic variant is KRAS mutation, followed by EGFR, followed by ALK. But Asian population, particularly in India, the most common genetic variant is EGFR. Next. There are different testing methods available for these biomarkers, but the most commonly used method for EGFR is PCR-based test. Whereas for ALK and ROS, these being the fusion genes, we use a FISH method for it, and for PD-L1 we have ISC. Although these targeted agents like targeted markers like EGFR, ALK, ROS, they also can be diagnosed with NGS-based test. Next. EGFR is the one of the most common mutation in lung carcinoma, especially in Asian population. It is the most common target available, and we have different axonal mutation like exon 18, 19, 20, and 21. Out of these four, exon 19 deletion and exon 21 substitution is the most common type of EGFR mutation, and the other rare variants are like exon 20 skipping mutation and exon 18 substitution mutation. Next, please. As I already discussed, that in Asian population, the EGFR mutation is much higher than the Caucasian population. Asian population, the EGFR incidence is around 30 to 40%, whereas in Caucasian, it is around 10 to 20%. But as you can see, stage-wise distribution, the incidence of mutation is quite similar. It is around 25 to 30%. Next, please. NCCN recommends that EGFR testing should be done in all cases in early lung cancer also, as well as in advanced. In early cancer, especially after stage 1B and up to stage 3B, because we have adjuvant targeted agent like adjuvant osimertinib or alectinib in cases of post-surgery and post these cases, we have now recommendation for this targeted agent. So EGFR testing should be done in all early cases also, along with the advanced cases. Next, please. This is the mechanism of action of EGFR agent. EGFR wild type, they have on stage and off stage. Usually they are remain in the off stage, but when the ligand is bound to the EGFR target, this molecule dimerize and they activate the downward pathway, and this downward pathway lead to transcription, protein synthesis, proliferation. But in mutated cases, these EGFR molecules, they are always on stage, that even without the presence of any ligand, these remain activated and they activate the downward pathway, leading to more cell development, proliferation, transcription, and protein synthesis. And ultimately, this leads to the cancer development. Next, please. This slide has already been discussed in the previous talks, because the current guideline is based on the management is based on different biomarkers, like we have different target available like EGFR, ALK, and then we have PD-L1 status. Based on this, we choose the chemotherapy as well as the different targeted agents. So I'll not discuss about this detail. I'll just focus on the EGFR positive status. For EGFR mutation, we have first line, second line, and third line. And those with T790M mutation, we have only osimertinib. Now, the first line and second line, they are not much used nowadays. Nowadays, the preferred regimen is osimertinib, that is third line EGFR agent. Next, please. Next slide. Osimertinib is a third generation irreversible CNS active EGFR TKI, selective for both mutated as well as T790 resistant mutations. So osimertinib, it acts by inhibiting the EGFR mutated molecule, and as well as it also inhibits T790M variants, and it has lower activity against the wild type variant, and it has very good CNS penetration, that is blood-brain penetration. So it is very active in those patients who have CNS mets. Next, please. The approval of osimertinib is based on the FLORA data. FLORA trial is a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus the standard of care TKI as a first-line treatment in patients with locally advanced or metastatic EGFR mutated non-small cell lung carcinoma. Next. The inclusion criteria was patient more than 18 years of age and the PS performance status of 0 or 1, and those patients with exon 19 deletion or L858R mutation, and no prior systemic therapy or any TKI therapy was allowed, and stable CNS mets was allowed. The study population was divided into 1:1 ratio. The arm A received osimertinib 80 mg OD, and the arm B received first line or second line TKI like EGFR TKI like ejeftinib 250 mg OD or erlotinib 150 mg BD. And the crossover was allowed, and after 6 weeks the assessment was done, and the primary endpoint was PFS by the investigator, and secondary endpoint was overall response rate, objective response rate, duration of response, disease control rate, depth of response, overall survival, and safety. Next. In FLORA trial, the baseline characteristic was balanced across both the arms, including the smoking status, CNS mets, performance status, histology, and EGFR mutation. All the parameters were balanced across both the arms. Next. So coming to the result, efficacy, it was the primary endpoint. The PFS was the primary endpoint by investigator. And as you can see, the Kaplan-Meier curve was separated early and keep on separating till the end. So the median PFS was 18.9 months for osimertinib versus 10.2 months for the comparator arm, with hazard ratio of 0.46. So osimertinib reduced the risk of progression or death by around 56% compared to the standard of arm. Next, please. Subgroup wise, as you can see, almost all the subgroups like age, sex, race, smoking status, CNS mets or not, all the subgroup favors the use of osimertinib as compared to the other TKIs, first generation or second generation TKIs. So a consistent benefit was seen across all the subgroups. Next, please. Objective response rate was also better when you use osimertinib. It was, as you can see, it was 80% versus 76%. And the duration of response was also better with osimertinib. Median duration of response was 17.2 months versus 8.2 months, almost doubling of the response, duration of response when you use osimertinib as compared to the first generation TKIs. Next, please. Now, the finalized FLORA OS data has come, and 3-year OS, we can see that it is around 3-year median OS was 38.6 months versus 31 months comparator arm. The final analysis of OS demonstrated clinically meaningful and significant improvement of overall survival for osimertinib versus other TKIs. Next, please. Adverse effect. This drug is well tolerated, and there's not much adverse effect as compared to the other TKIs. The most common adverse effect are like diarrhea, rashes, dry skin, stomatitis, cough, etc. But grade 3 or grade 4 are very less than 2 to 3%. So overall, this drug is quite tolerable and safe as compared to the other TKIs. Next, please. Same thing. It is any type of adverse event around 97% in osimertinib versus 97% in the standard of care. Although the death was only 2% versus 3% in standard of care. So the overall tolerability is quite good for osimertinib, and it is well tolerated and safe drug. Next, please. So summary, osimertinib resulted in highly statistically significant and clinically meaningful improvement in the PFS over other standard of care with hazard ratio of 0.46. So there is 54% reduction in risk of progression or death as compared to the standard of care. And the benefit is consistent in all predefined subgroups. And there was doubling of duration of response with osimertinib, 17.2 months versus 8.5 months. A significant and clinically meaningful improvement of CNS PFS was also seen with osimertinib with a hazard ratio of 0.48. So there are only few CNS progression events seen with osimertinib. And final analysis of OS result showed promising survival trend towards the osimertinib with hazard ratio of 0.799. And so as there is a trend towards the improvement of OS, we should use this as a first line choice. And the safety wise, it is comparable to the other TKIs, and overall it is safe and tolerable drug. So osimertinib is the new standard of care for first line treatment in patients with EGFR mutated advanced non-small cell lung carcinoma. Next slide. Coming to the CNS efficacy. Next. As you can see, the diagnosis CNS mets occur in patients with EGFR mutated at higher frequency than the wild type group. As you can see in this flora tile, the brain mets were in EGFR positive patient, it was around 19 to 24% at initial diagnosis compared to only 11 to 13% for those who are wild type. And during follow-up, for EGFR mutated patient, we have brain mets of 44% versus 22%, almost double of that wild type group. And for leptomeningeal metastasis, for mutated group, we have 9.4% as compared to 1.7% in wild type group. So EGFR mutated groups, these are a high risk group. They have high incidence of brain mets and leptomeningeal mets. So CNS activity, PFS was better with CNS PFS was better with osimertinib, irrespective of presence of CNS mets or no mets. As you can see in the first curve, there is separation. So with the median PFS was 15.2 months with osimertinib, it has a ratio of 0.47, and with those without CNS mets, the osimertinib arm, they have median PFS of 19 months versus 10.9 months. So osimertinib benefit was consistent in patients with or without CNS mets, and fewer CNS progression was seen when I use osimertinib. Next, please. Same thing, the CNS activity is better. So CNS PFS is better with osimertinib arm with hazard ratio of 0.48. Next, please. Next slide. Now let's compare osimertinib with other second generation TKIs. Although there is no head-to-head trial, these are the cross-trial comparison. So these studies should be taken with caution. Next slide. Dacometin is a second line EGFR TKI, and it is the approval was based on Archer study. And as you can see, the PFS in the Archer study for dacometinib, it was 14.7 months versus 9.2 months for gefitinib, with hazard ratio of 0.59. Wherein for Flora study, the PFS was 18.9 months for osimertinib, with hazard ratio of 0.47. But it is important to note that the curve remain overlapped for the first 6 months, and after 6 months there was separation of the curve for Archer study for dacometinib. But you can see in the Flora arm, Flora trial, the curves get separated early, very early. So the benefit was seen from the first month onward. But for dacometinib, the benefit was seen after 6 months. Next slide. So, and also the Archer study, also there was some OS benefit, but it was not significant because in Archer study they use different hierarchical testing methods, and they used overall response rate as a parameter for calculating overall response rate. As ORR was not statistically significant, so the OS benefit was not statistically significant in Archer study. Next slide. But in Flora trial, there was a significant OS benefit. Median OFS was 38.6 months for osimertinib with hazard ratio of 0.779. And this hazard ratio is there. The benefit of OS is there even when there is crossover is allowed. So even with crossover, there is OS benefit with osimertinib. Next slide. So early and sustained benefit with osimertinib. Same thing, Archer study, there is some OS benefit, but it is not meaningfully clinically significant because the overall response rate value that is not significant for, so the OS is not significant for Archer study. Next is osimertinib versus afatinib. Afatinib is a second line EGFR TKI. It is based on the LUX-7 study. The PFS was there for afatinib versus gefitinib. The median PFS was 10.11 months versus 10.9 months, but the osimertinib has better PFS of 18.9 months. So, and for Lux study, the data was insufficient for study for the purpose of OS. So OS analysis could not be determined with afatinib. Next slide. Same thing. The OS benefit was could not be determined in the Lung-7 study. So overall OS was 27.9 versus 24.9. It is not meaningful and clinically significant. Next slide. Same thing. Those patients in Lux study subgroup analysis, exon 19 del and L85A mutation, they saw similar OS trend when we use afatinib or gefitinib. So there is no OS benefit with afatinib. Next slide. So these are the different safety analysis for all the trial. This is a cross trial comparison, so should be taken with caution. In Flora study, osimertinib, they have very less side effect, like only 92% diarrhea or less than 1% paranoia and stomatitis, and dose reduction is required only in 5% cases. But in Lux study, for afatinib, there was high risk of skin rash, like 13%, with the diarrhea rate is around 9%, and dose reduction is needed for 2%. And in Archer study for dacometinib, skin rash is seen in 13% patient, and diarrhea is seen in 8% patient, and dose reduction was required in about 66% patient. So out of these all, osimertinib is quite well tolerable, and they have very less incidence of side effects. Next slide. So what is the place of osimertinib? Will it be in the first line, or is there any benefit for using the second line, or is there any role of sequencing? So in many cases, because of the financial constraint, we use sequencing, like we give first line TKS first, and then second line, then ultimate third line. But when you use that type of approach, the overall benefit is less. But if we use the that osimertinib as the first line, the PFS is much more than the sequencing arm. So the first line osimertinib has better result compared to the sequencing arm. So in any case, whenever possible, we should use osimertinib as the first line and the preferred choice. Next slide. So there is also some evidence that when you use first line or second line TKIs, there is development of T790M mutation. But the patient who will develop T790 mutation, we cannot predict. Out of 10 patients on first line or second line TKIs, only 7% will 7% that is 70% will receive osimertinib. 30% of the patient will not get any opportunity to receive any second line or osimertinib. So we'll lose around 30% of patient if we don't use osimertinib. So osimertinib should be the first choice. Next slide. So use of osimertinib as a second line in the FLORA study has shown that in about 30% of the patient in the comparator arm in the FLORA trial also receive osimertinib, and no, could not receive any type of second line or third line treatment because they die or they given best supportive care. And in the comparator arm, around 47% of the patient received second line osimertinib as they have T790M mutation. So in total, 31% the all patients in the comparative arm received osimertinib with the second line choice because crossover was allowed in the FLORA trial. Next slide. So there are some real world evidence available in across different countries like in Germany, US, Japan. In all the trials, all the studies we have seen that when you use osimertinib as a first line, the PFS is much more higher, and in the second, when you use it in the second or third line, around 20 to 30% patients will not get any chance to have it because of their poor performance status or the poor general condition. So we should, whenever possible, we should use osimertinib in the first line. Next slide. This is the latest NCCN guideline. As you can see, those patients with EGFR 19 deletion or EGFR exon L58R mutation, osimertinib is the first and preferred choice, and others are the second or next choice. So conclusion, for the first time in the evaluation of EGFR TKIs, osimertinib translated the PFS into significant OS benefit. And osimertinib has median PFS of 18.9 months and median OFS of 38.6 months, which is significantly higher than other first line and second line EGFR TKIs. Osimertinib has shown efficacy in patients with CNS mets, and there was fewer CNS progression events observed with osimertinib, like only 6% as compared to the other TKIs, like 15%. And fewer and less severe adverse effects were found in osimertinib arm. So as it has a better safety profile than other TKIs. So overall, osimertinib is the first line standard first line choice for EGFR positive advanced non-small cell lung cancer. Next. Thank you. If you have any question, I'll have to answer.
Thank you so much, Dr. Debajyoti sir. So is there any questions? So thank you so much all the faculties to join the webinar, and thank you so much AstraZeneca to organize this event. So good night everyone. Thank you tech support. Thank you for support me Shakshi. Thank you all. So tech support, can you please close the meeting?
Thank you. Good night.